Greetings. My name is Gwen McMillan, and I am a medical director at ARUP Laboratories and also an associate professor of pathology at the University of Utah. And I'd like to spend the next approximately 10 minutes highlighting some of the ways in which the clinical laboratory can support what has become a rapidly growing area of medicine, specifically the management of patients with chronic pain. The major reason for laboratories to support this area of medicine is the need for routine drug testing in this population. So I'll begin with an overview of how a typical pain management clinic may approach patient care. So first of all, patients are evaluated to diagnose the type of pain and, if possible, the underlying pathophysiology or source of that pain. During this clinical assessment, providers will determine if the underlying condition would benefit from opioid analgesia. If opioids are indicated, then providers will assess the likelihood that a patient will exhibit aberrant drug behavior, which may include things like hoarding, diversion, abuse, or simply misuse of a drug. As part of this evaluation, clinical practice guidelines recommend a baseline urine drug test to detect drug use prior to initiating opioid therapy. Once prescribed opioids, patients are evaluated routinely for response to therapy and also for adherence to therapy with regular urine drug tests. So this slide simply summarizes the objectives of the drug testing in this patient population. That is, first, to detect appropriate drug use or adherence to therapy, and second, to detect and discourage inappropriate drug use or non-adherence. Now, this area of testing presents lots of opportunities for the clinical lab to partner with providers, ranging from a very active role to a more passive consultative role. Some of the obvious opportunities include applying or sharing the expertise of the laboratory in test selection, test performance, both in the lab and in the clinic. In addition, laboratories may play more of an administrative role, guiding utilization, coordinating referral testing, and managing the billing and reimbursement side. Now, there's two major types of drug tests that are performed in this area: screens, which identify drugs and drug metabolites, and targeted tests, which identify those drugs and drug metabolites with much higher specificity and may also provide quantitative results. Now, with the screens, there are point of collection or very rapid tests that are available, such as delivered through urine cups or cards, and also more complex methods that are available on automated analyzers that are common to most clinical laboratories. The reimbursement structure for these types of tests varies quite a bit, as illustrated on these slides, from the point of care, which would be a low or moderate complexity approach, to the higher complexity screen performed with an automated analyzer, confirmation testing, which is more targeted, and also consultation, which is available to MD pathologists. So hopefully you can recognize that clinical laboratories who are familiar with, of course, testing methods and with coding of such tests are well positioned to work with pain management providers to establish the best approaches to meet their needs. So, for example, we can run through a few of these. A point of care screen might be most appropriate for a clinic that needs the results while the patient is in the clinic. So needs results within a few minutes of specimen collection. Some clinics that are particularly interested in this type of rapid test are going to be those clinics which deal with very high-risk patients and those clinics that might manage patients who travel far distances for care. It's also desirable for a clinic that does not have necessarily a complexity license through CLIA, because essentially anybody can perform the low complexity or CLIA waive tests. Now, the automated screens, those which are familiar to many that work in the routine clinical laboratories, are of great interest for clinics that have low-risk patients or for which the patients are in the local area and could easily be accessed for follow-up visits. So once the screening results are available, providers may receive conflicting guidance as to next steps. In a traditional workplace drug testing environment, the approach would be to perform reflex confirmation testing for all drugs that test positive in the screen. However, this approach may not align well with the needs of a pain management clinic, and hopefully the rest of this presentation will convince you of that. Instead, what we want to do is evaluate results based on expectations. So certainly a positive drug screen that can be paired to a drug prescription and/or patient history is expected, and it's not necessary to confirm that result unless quantitative results are required or unless those results are used to guide future management decisions. In contrast, when a result is unexpected, either positive or negative, then confirmation testing may be very appropriate. Certainly a positive that's unexpected could be a false positive, or it could represent aberrant drug behavior such as abuse or doctor shopping. An unexpected negative could represent a false negative or non-adherence, so failure to comply with therapy, or perhaps diversion. So by interpreting based on expectations, one would consider the result relative to the pharmacy history and the patient history. If the results are consistent, then most likely no further action or additional costly tests are required. If the results are not consistent, then an investigation should ensue to evaluate those unexpected results through discussion with the laboratory and discussion with the patient. And as needed, follow-up testing, which may be qualitative or quantitative. So what is the utility of the follow-up testing? First of all, to resolve possible false positive or false negative results. Follow-up testing may also evaluate adherence for drugs that are not detected by the screens, may help determine metabolic phenotypes, which can be used to support longitudinal monitoring of a patient over a period of time, and may identify drug-drug interactions for that patient or other changes in pharmacokinetics. And this illustrates some of the types of follow-up testing that might be available. So targeted testing is what I would consider traditional confirmatory testing. So this is utilizing a technology that has high specificity or sensitivity, such that we can confirm the identity and quantity of an individual component, figure out what's responsible for that positive result, or investigate why a screen result might be negative. Or an expanded screen, which would be based on mass spectrometric detection instead of immunoassay. And this, of course, would be the most comprehensive approach, but may not produce quantitative values. So this is a very useful approach for situations where drugs are known and are not covered well by an immunoassay screen, or where drugs are simply not known. And so I'd encourage you to consult the laboratory to look at options for expanded screens. And now I'm going to finish by going through a couple of the case examples that will apply some of these principles. So if we had our first patient who was prescribed methadone and lisdexamfetamine dimesylate, which is a trade name Vyvanse, do a screen and it's positive for methadone, amphetamine, and THC, indicative of marijuana use. So the methadone matches with the prescription, as does the amphetamine, because the Vyvanse is a prodrug that is metabolized to amphetamine. In terms of the negative screen results, the screen was negative for methamphetamine, suggesting compliance with the Vyvanse only. It was negative for oxycodone and other opiates, suggesting that the patient is being compliant with just the methadone. Now, what about the THC? Well, it turns out the patient admitted to occasional use of marijuana, and the patient overall is classified as moderate risk. So when interpreting based on expectations, I would say that the results are consistent with expectations and there's no need for additional testing. If, in contrast, we used that reflex testing approach, then 3 confirmation tests would have been ordered, and additional office visits may have been required, leading to unnecessary expenses and inconvenience to the patient. The second example deals with a patient who is prescribed oxycodone, hydrocodone, clonazepam, and Ritalin, or methylphenidate. The screen results are positive for oxycodone and opiates, negative for benzodiazepines, amphetamines, and the other drug classes that are being tested. So the oxycodone matches. The hydrocodone is most likely triggering the opiate result, so that matches. The clonazepam was not detected by the benzodiazepine screen, which raises some questions. And the reason for including amphetamine in this list of negatives is to make the point that methylphenidate is not typically picked up by amphetamine tests, and this is a common misconception among laboratories. Now, in terms of approaching the patient insists on adherence to therapy and is classified as low risk. So what do we do next? Well, based on expectations, we'd say results are not entirely consistent with expectations. So talking to the lab, we find out that the benzodiazepine screening test that was performed has very poor sensitivity to clonazepam, and so a negative actually is expected. And also that methylphenidate is not picked up by that amphetamine screen. So all in all, that means that results are actually fairly consistent, and we'd recommend periodic confirmations based on the patient risk profile, or if actual concentrations or results are needed to make clinical decisions. Contrasting that with the reflex testing approach, in this scenario, 1 confirmation test would have been ordered, and 2 false negatives would remain unresolved, which overall could compromise patient care and the relationship between both the physician and the laboratory. So in conclusion, I think clinical laboratories are in an excellent position to actively participate and or consult regarding the drug testing needs of chronic pain management patients, and that utilization of testing should be based on the clinical needs rather than reflex testing approaches to improve patient care, integrity of laboratory testing, and relationships with physicians, as well as to minimize costs. Thank you for your attention.